Good morning, everyone. My name is Aarti Prasad. I am the new Chief of Medicine at HCMC, formerly called HCMC. Now the new name is Hennepin Healthcare. And I came from University of New Mexico about 8 months ago. And because of my UNM connection, I had invited Dr. Arora here to the university and to Minnesota and to HCMC to talk about Project ECHO and the wealth of services and knowledge that Project ECHO has produced all over the world. So I just want to formally introduce him. This is Dr. Arora, who's the founder and director of Project ECHO, and ECHO stands for Extension for Community Healthcare Outcomes. He's a distinguished professor at the University of New Mexico, and he developed this model in 2003 to increase capacity and access for specialty care in rural areas and underserved and to benefit underserved populations. He created an interdisciplinary team of experts, and you will hear from him more about the model, so I won't say much about it. But I just want to say that the Project ECHO has impacted not only one country, but 27 countries, lots of academic health centers around this country, and it has grown its funding to $65 million from federal and state agencies as well as from foundations. And Dr. Arora has received many awards nationally and internationally for his innovative work. And he was not only able to do that, but also had an impact through ECHO Act, which was passed unanimously through both houses of Congress on December 14, 2016, and President Obama signed the ECHO Act. And the long-term goal of ECHO Act is to study the impact of Project ECHO in the U.S. health system. So please join me in welcoming Dr. Arora to Minnesota, and thank you for creating this opportunity here at the Cancer Center.
Thank you. So maybe I'll tell you a little bit about myself while it gets loaded. So I was born in India, and my parents were both physicians, and my father was a physician in community health, worked for the National Institute of Communicable Diseases, and even though I saw very little poverty when I was, a kid, a small kid, but when I was around 8, 9 years old, in the summer when my dad used to go around on these Jeeps, the kind you used to see in MASH television show, where they open, and I would sit with him. You had to hold on tight as we went so you don't fall off. And I would go to these rural areas and see this enormous poverty. This one, the first one. Okay, thank you. Yeah, this one. Yeah. And I saw a lot of poverty, and at that point, I really got interested in service to humanity. And then what happened was I became a teenager, and I forgot everything about it, and got much more interested in doing my own thing, developing myself. And then somewhere in mid-30s, this idea came back to me that I wanted to spend my life much more in service. And sort of ECHO is a byproduct of that desire for me to serve and make a bigger impact in the world. So our ECHO, our mission is to democratize medical knowledge and get best practice care to underserved people all over the world. We have a goal to touch the lives of 1 billion people by 2025. And we have received now about $100 million of funding from all different sources like foundations, federal government, all different branches of federal government fund us. The key strategy to get to 1 billion people is to move knowledge instead of moving patients or providers. As we were mentioning, I'm a gastroenterologist. I was treating this disease, hepatitis C, in 2003. It's a disease that affects 70 million people worldwide. It has a 28% lifetime mortality. But of the 28,000 patients that have been diagnosed in New Mexico in 2003, less than 5% had been treated. There were 2,300 prisoners. None had been treated. And what was happening was these patients were coming to see me. In my clinic, there was an 8-month wait to see me. I was treating with interferon ribavirin, but with an 8-month wait and people driving hundreds of miles, making 12 trips to see me, literally poor people didn't have a chance to get treatment. And so people living in rural areas had very little access. People started coming to see me with liver cancers, liver failure. So I said, oh, I need to do something different. And the problem really was it was curable between 45 and 70% of the time, depending on the genotype. So genotype 1 was 45%, 2, 3 was 70%. And because of the side effects of anemia, neutropenia, and depression, not a single primary care doctor in New Mexico was treating hepatitis C, not one. And so as a result, access was poor. So we developed ECHO to safely and effectively treat hepatitis C all over New Mexico, and then we knew we would have a model to treat complex disease in rural locations and developing countries. ECHO uses technology, as I'll show you, but the value in ECHO is created fundamentally through collaboration. So we developed partnership between university, prisons, health department, Indian Health Service for Native Americans, and federally qualified health centers. And if you have to remember one slide, this is the one to remember. There are 4 key principles on which Project ECHO is based. First is to use technology to leverage scarce resources. What was that? In this case, that was a liver specialist, a hepatologist, a psychiatrist, and a pharmacist. I needed all 3 because interferon was causing a lot of toxicities, and ribavirin pharmacokinetics are a little bit complicated. So it's hard enough to get all 3 in a rural area or even in a university. Rural area was impossible. So we said we would get them and use technology, one-to-many video conferencing like Hollywood Squares. The second key principle in Project ECHO is to share best practices. This is based on the work of Edward Deming. Edward Deming was a mathematician. He described a concept in the 40s called statistical process control. He said, look, if you want to improve quality, you want to standardize across best practice. You want to develop one good way of doing something, and then you want to standardize it so that all parts of your system have the same outcome. He played a very important role in the Second World War as part of the Allied forces. But after the war was over, he came back to the US automobile industry and told them, I'm going to teach you how to make better cars. They said, look, we make great cars. We have 90% of the market. Why would people buy them if they weren't great? He left the United States and went to Japan. He worked for Toyota Corporation. And of course, the rest is history. You know that most of our automobile industry went bankrupt, largely because the quality was poor. It was inferior to Japanese cars, and that was just not a sustainable problem. So in medicine, we call it disease management, but we had a protocol. Our American Association for Study of Liver Disease has a guideline for treating hepatitis C. So what we did is we created 21 centers of excellence for treating hepatitis C in New Mexico. 5 of them were in the prison system, and 16 was in existing federally qualified health centers. So what did you need to have to be called a center of excellence? You needed 2 things. First, you needed either a nurse practitioner, a family doctor, internal medicine doctor, or a physician assistant who was willing to become a hepatitis C expert or specialist. Second, you needed the leadership, of course, to buy in that they were going to create a center of excellence in their community to serve their patients. So we did this 5 prisons, 16 FQAC, and we shared our protocol with them, ASLD guideline. But guess what? Not a single one was willing to treat hepatitis C based on seeing our ASLD guideline. And so I asked myself, how did I become an expert? I was not born that way. So I did my fellowship in Boston, and from the first day, I would see a patient present to my professor. Marshall Kaplan was my mentor. I would see a patient present to my professor, and I kept doing this nonstop for 2 years, after which they started calling me a gastroenterologist. I said, aha, I'm going to use this same model to create new hepatitis C-ologists in New Mexico. That is the essence of ECHO. Case-based learning to master complexity, and we would use the web-based database to monitor outcomes. So what do? We train these physicians, physician assistants in hepatitis C, train them to use our web-based software. Then we started Wednesday afternoon, 3 p.m., once a week. In 2003, I started running these tele-echo clinics. This is what one looked like. In the big box is the liver specialist. I used to have black hair at that time, a pharmacist, and a psychiatrist. And all 21 would join together on an interactive video network. First, Deb Newman would present a patient of hepatitis C to me. I needed about 20 pieces of information to make a good decision on a hep C patient. She would give me all 20 in about 5 minutes in the template. Then I would ask everybody else, all the other 20 sites, if they had any advice, any questions. Then our team would discuss the case. We'd give final recommendations and then move to Las Cruces. They would present a case. Over the course of about 2 hours, we would co-manage about 10 patients in a de-identified way. And for 15 minutes of the 2 hours, you would give them a lecture, standard lecture on something about hepatitis C. Every echo clinic is pretty standard. 1 hour, 45 minutes cases, de-identified, and 15 minutes lecture. It's important not to make an echo clinic a lecture alone. This is called a knowledge network. No patient ever comes on the network. And what we found was that these clinicians, primary care clinicians, started becoming great experts in a year through a process which we've described called a learning loop. They learned from our advice on patients. They learned from our lectures. They learned from each other because they brought one patient to the network, and they learned on 10 every week and 300 in a year. But mostly they learned by doing. How many of you have taught your son or daughter to drive a car? Can you raise your hand? So if I told you you could just give her lectures on how to drive a car, would you give her the keys to the car? What if she took a written test and scored 100%? Would you give her the keys to the car? And there's a reason why you don't give her the keys to the car. Because when there's a complex problem like this, you're going to have a big problem with just lectures and books. You need iterative guided practice. You need someone to hold your hand, in a sense, while you do this under guidance, and then you become an expert, and that's how the learning loop works, and we track outcomes. So we gave them no-cost CME credits. We gave them interaction with colleagues of similar interests by bringing a mix of work and learning and giving them access to multiple specialists. So a big question you'll be asked, and I'm pretty sure the Department of Medicine already does this, is you do telemedicine, isn't it? Do you ever do telemedicine here? You do, a little bit, right? So what's the difference between telemedicine and tele-echo? Telemedicine is when a specialist at the University of Minnesota manages a patient at the remote area over a camera. It could be very effective to overcome a geographic maldistribution. But it's not very effective if you have an overall shortage of specialists. Because if you put a patient on your specialist, if I put Dr. Hassan on the camera, he's going to see one less patient in the university here. That's not going to increase capacity. The total number of patients seen in Minnesota will be the same. Whereas in echo, the idea is an expert multidisciplinary team trains an expert team, primary care clinicians and nurses and community health workers who will then treat hundreds of patients. That's the goal of echo. Massive capacity expansion. And the only technology a rural clinician needs is a webcam and internet access. As part of our partnership, if you decided to partner with us, we will give you all the technology you need. We'll give you the training you need. We'll give you the software to run echo projects, and we will give you no-cost access to all of this training and everything, but also our worldwide video conferencing platform. That is, you could have spokes from Somalia joining, from Ethiopia joining, from Kenya. It doesn't matter, okay? It will give you the worldwide Zoom platform to really access. You'll have your own accounts, and we'll give you the software. So we've done 600 such tele-echo clinics. We've managed about now almost 8,000 to 9,000 patients already with hepatitis C, treated them. And provided about 80,000 hours of CME credit at no cost to our rural doctors in New Mexico. We only have about 3,000 primary care clinicians total clinicians in New Mexico. So this is a lot of CME credits for each one. So we wanted to study self-efficacy, and since there are two hepatologists, we published this data in Hepatology in 2010, where we assessed self-efficacy. We said no doctor would be willing to give interferon unless they had confidence they could do a good job. Scale here is 1, I have no skill. 7, I'm an expert who can teach others. We asked them, what is your ability to treat hepatitis C and manage side effects? 2 out of 7 goes to 5.2 in 12 months. But look at this question. Can you identify candidates for treatment? They can't even do that. 2.8 to 5.6. In the baseline, they can't. Can you manage psychiatric comorbidities? Because interferon was being given and it causes depression. 2.6 to 5.1. Can you now become a local consultant within your clinic and area? 2.4 to 5.6. So what does this mean? Because we had 28,000 patients in New Mexico, if these doctors just treated their own patients, that would not solve the problem, because a doctor may only have 5 hepatitis C patients in his practice. They had to treat the whole community. So first they treated their own patients, then they treated everybody in the local area. Everybody in the town started going to them for treatment. The wait in my clinic was 8 months. It fell to 2 weeks after 18 months of doing it. That means every week I did this to our clinic, 21 centers, and even today, 14 years later, the wait in my clinic is about 2 weeks. So overall competence went from 2.8 to 5.5. But the important thing to remember is ECHO is not about transferring all the care from an academic center like University of Minnesota to the periphery. It's the right care at the right place at the right time. And that means sometimes if a person needs my help, they have to come here because they need an MRI scan, they need a CT scan, they need a biopsy, they may need a fibroscan, they may need liver transplant evaluation, they have decompensated. There's all kinds of reasons, but the effective triage system makes sure that if you can be provided care there, you get provided care there, and if you need to come, you come. We wanted to know, we knew patients were benefiting because the waits were small, access was good, and cure rates were high. But we wanted to know, do doctors benefit? And 97, 94, and 98% felt that achieving competence was beneficial to them. Has it diminished your professional isolation? 4.3 out of 5. Enhanced my professional satisfaction? 4.8. Benefit to my clinic? 4.9. Expands access to HCV treatment? 4.9 out of 5. Access in general to specialty expertise is a major area of need for you and your clinic. This was a perplexing question because here's what happened. You can see here that in the United States, we have more specialists than any other country in the world. We have 50 times that of Africa, and yet our rural doctors say they can't access specialists. So we have estimated 6 billion people in the world don't have access to the right knowledge at the right place at the right time. So they can't get the right care at the right place at the right time, and millions of people die because of lack of this knowledge, even though the right medicine is present in the town. It could be a generic medicine in the clinic next door in Ethiopia, but if the doctor can't make the diagnosis, then there is no hope. So that's the problem we're trying to solve. Of course, it's not good enough that doctors are happy and enjoying themselves. The issue is, can they do as good a job as a multidisciplinary team at the University of Minnesota? We studied that. This was published in the New England Journal of Medicine, and my colleagues in GI may have seen this paper at some point. But what we did is we did a head-to-head study between these rural areas and prisons and the university, and objectives were to train primary care clinicians in rural areas and prisons to show that such care is as safe and effective as a university clinic. We can improve access to care for minorities. We took 21 intervention sites, 16 community-based clinics, 5 prisons. Control was UNM liver clinic. Principal endpoint was sustained viral response for the non-liver specialist. This means a lifelong cure of the virus. If we get a cure, even if somebody has cirrhosis at the baseline, they have a 70% reduction in likelihood of getting liver cancer over about 10 years. If they don't have cirrhosis, they get to be normal again. And if they have cirrhosis, then their likelihood of dying from liver failure goes down by about 90% too. So these are the results in the New England Journal. Cure rate for genotype 1 was 50, 46, 2, 3 was 70, 71, no difference. Minorities were 68% in ECHO. We showed that rural primary care clinicians deliver Hep C care under the aegis of ECHO that is as safe and effective as a university, and we can improve access to care for minorities. The interesting part of this was that there was a very large trial called the WIN-R trial. The WIN-R trial examined private practice GI doctors treating hepatitis C in the United States, same protocol as us. They had a cure rate of only 34%, whereas we had 50% in our rural sites. It was higher. So we were perplexed. We looked at the VA, where you work. In 2009, the VA had reported exactly with the same medicines, genotype 1 cure rate on naive patients of only 20%. You probably had seen that data. We were perplexed. Why was our rates higher? And we think that treating patients close to their home in a culturally appropriate setting by doctors whom they know and trust them, and you have psychiatry in there, cure can be better. Because we figured out what was happening in the VA and in the WIN-R trial for private practice GI doctors. When people have to travel long distances, if it was a snow day, they didn't show up. The next appointment they got was 3 weeks later. Adherence suffered. And over time, this undermined the cure rate, basically, of hepatitis C. In fact, there was a rule called the 80-80 rule with interferon ribavirin. Do you guys remember that rule? The 80-80 rule, that if you missed more than 20% of the doses of treatment, cure rate actually went down from 50% to 20%. And this is what was happening here. So we described, of course, this is not a hepatitis C talk, it's a talk about ECHO. So we described 6 criteria. If the disease is common, management is complex, new treatments are coming, high societal impact, serious outcomes of untreated disease, and if you have effective treatment, you could use this model. We use the Pareto's principle. So we said in medicine, in any particular state, 20 to 25 disease areas account for most of the morbidity, mortality. Chronic pain, rheumatology, substance use, mental health disorders, etc. And if you start ECHO for all 20, you'll have a huge impact because they'll be accounting for a lot of the morbidity. And we cut horizontally by producing the same level of care at a community health center as we do at a university. This is the second most important slide. This is the goal of ECHO. It's called force multiplier. That is, we want to exponentially improve the capacity to deliver best practice care, 10 times to 100 times more. And I'll explain why we need that. Because if all of a sudden we double the number of specialists in the world from what the current exists, then you will have 5 billion underserved patients instead of 6 billion. It won't solve the world's problem. You need exponential capacity expansion. And if you can have a nurse practitioner produce the same level of care as a super specialist, then that happens. These are all the ECHO projects. We have now 35 ECHO projects going on in New Mexico. Rheumatology, TB, cardiology, seizures, osteoporosis, hepatitis B, endocrinology, diabetes, minors wellness, antimicrobial stewardship in rural hospitals, addiction psychiatry, opioid addiction, nurse practitioner training, and so on and so forth. This is a paper in Health Affairs in 2011, studies done in all these other ECHO projects that we were doing, not hepatitis C. I'm learning best practice care, 4.68 out of 5. Fifth question, I'm developing my clinical expertise, 4.48 out of 5. Fourth question, I apply what I have learned about best practices through ECHO to all my patients with similar chronic diseases. So ECHO is not about, it's not a teleconsultation service to help the people who are presented to you. It's to help everybody in the community with that medical problem and putting an effective triage system so that the ones that need to come to the University of Minnesota come right away, and the ones that can be provided care there get provided there. This is ECHO age out of Harvard, 2-to-1 matched cohort study, 11 nursing homes, 22 controls. Residents in echo-age facilities were 75% less likely to be physically restrained and less likely to receive antipsychotics. This is a paper out of University of Rochester, Geriatric Mental Health. There was a 20% reduction in ED visits and 24% reduction in overall cost. This is what a full-blown echo looks like. And this is, we have 400 points of contact in New Mexico, in clinics, and in each town we'll put one expert in rheumatology, one in hepatitis C, one in HIV. So they create a self-sustaining network to help people rapidly when they need help locally. This is our addiction network. All over New Mexico, my colleague Dr. Kumarami has set up addiction treatment sites. This paper that she developed had got the award for the best paper of the year in 2016, where she was able to show that the number of Suboxone certified providers in New Mexico increased 4 times over the national average. So there were 33 doctors who had that licensure. She trained 500 more using echo, and all of a sudden access improved. This is the reason why I'm actually here. Medical knowledge is increasing exponentially, but learning capacity is only going up slowly of primary care clinicians. So disparities are getting worse. And what do I mean by that? Breast cancer mortality rates in blacks and white women were the same in 1979. Today, black women mortality rates are 43% more than white women. Why is this happening? New knowledge is coming, and we can't get it to the last mile of healthcare. That means the current model of training providers in this country, training them in residency, sending them out, etc., and not giving them any more support, systematically will keep increasing disparities in the world over time. Not for breast cancer, for everything. For every single disease area which is complex, disparities will keep increasing unless we develop a new way to distribute this knowledge to the last mile of healthcare. That's what we're trying to do. ECHO is also about training community health workers. I'd rather have a discussion, so I'm going to go a little fast, so we'll leave about 15 minutes for discussion. But this is the idea that chronic disease management is a team sport. ECHO is not about training doctors. We train nurses, community health workers, whole teams. This is data showing a community health worker added to a primary care team does twice as good at blood pressure, LDL, smoking cessation, because they live in the community and spend more time with the patient. We have 5 such training programs. Our CREW is our diabetes community health worker specialist program. We've trained 150 of them. And same model, they basically get 3 days of on-site training, get their webcams, present cases. We're not making them doctors, but we're making them patient education and support workers. This is our prison program. We've trained 500 community health workers in prison, who in turn have trained 10,000 prisoners now. Graduation ceremony of prisoners. The potential benefits of bringing ECHO to Minnesota could be in these categories: improve quality safety, rapid learning and best practice dissemination, more equity between rural and city areas, reducing variation in care, improving access for underserved patients, workforce training, force multiplier effects, improving professional satisfaction, supporting medical homes, cost-effective care, preventing cost of untreated disease, integrating public health. But the goal of ECHO is to democratize the knowledge of the University of Minnesota, which is very super specialty heavy, but that's needed with this new knowledge. We want to democratize it so that knowledge reaches everywhere. This is Albuquerque. This is our hepatitis C program in New Mexico, our 400 points of contact. This is the VA Scan ECHO network that you're going to start. I understand a Hep C ECHO on this. 11 university hubs, 600 clinics. They do it for 39 disease areas right now. This is the U.S. Department of Defense ECHO. They do ECHO out of Belgium, Germany, Italy, Japan, South Korea, etc. This is partnership with CDC, Good Health and Wellness in Indian country to improve Native American tribes' health. These are the 120 academic hubs that have launched ECHO. So Hennepin is one of them. University of Minnesota is also one of them, but also we have Harvard, Maine Health, Mass General, Partners Healthcare, Beth Israel Deaconess, Boston Medical Center, Johns Hopkins, Yale, MD Anderson, Texas, Missouri, University of Chicago, UCSF, essentially all the major universities have already launched echo projects, but we're just beginning in University of Minnesota, and I'm here to expand our collaboration with the Department of Medicine and with the Cancer Center. So that's the purpose. I'll show you, just to give you some ideas, I'm going to flick some slides one after the other. I'm not going to read them. I'll give you about 7, 8, 9 seconds per slide just to scan through them, what we are doing in the US. You can see University of Minnesota Pediatric Dental Health has launched. This is the VA. You can see we do all kinds of things in the VA, from behavior, mental health, chronic pain, women's health, and everything in between. This is our partnership in Africa to bring Namibia HIV control. They have 120,000 patients, 60,000 on treatment. We're trying to get the other half on treatment by connecting 40 rural hospitals. This is one rural hospital, people learning. Vietnam, multi-drug resistant TB. India, multi-drug resistant TB. These are the 29 countries we're in: Australia, Vietnam, Thailand, Kazakhstan, Kyrgyzstan, Tajikistan, India, Georgia, Egypt, Nigeria, Ivory Coast, Kenya, Tanzania, Namibia. These are the hubs in Africa. We have spokes in another 10 countries there: Uruguay, Argentina, Brazil, Ecuador, Jamaica, Mexico, Canada, and many European countries here too. So I won't tell you what we're doing worldwide. I want to focus on cancer a little bit too. Cancer incidence and mortality rates are higher in rural areas for colorectal, cervical, kidney, lung, melanoma, and oropharyngeal cancer. And the bigger problem is not that they are higher. The bigger problem is that these are both papers by the CDC in Atlanta, that these disparities are getting worse over time, significantly worse over time. So what do we do in cancer? We do echoes for prevention. We have 53 hubs now working in cancer. We have smoking cessation echoes, HPV vaccination echoes, HCV treatment, HPV, sun safety, skin cancer. This is for prevention. Screening and early detection for skin, breast, cervical, colorectal, oral, lung cancer. Pathology best practices, tumor boards, precision medicine. Survivorship echoes, because people get cancer care here and they go back and no one to take care of them. We have 10 hubs just doing palliative care all over the world. And so we are very interested, and as I was mentioning to you earlier, was that new hubs are starting for clinical trial enrollment, best practices in clinical trials for cancer, etc. This is the Echo Act that Dr. Prasad was talking about. And I want to thank her for arranging this meeting here, because I would not have been able to do it on my own. And Dr. Prasad is one of the most energetic, amazing, empathetic clinicians and leaders I've known. And I think Minnesota is so fortunate to have her here. And I think you're really fortunate to have her as part of your Department of Medicine also, to really contribute and bring her ideas. And the important thing here is when this ECHO Act went to the United States Senate, Senator Al Franken was a co-sponsor of this act. He was not just a voter. All 97 senators voted in favor of it, but he sponsored it. So he is interested in rural healthcare, and I think this is our team that has done this work. They got the award for the most disruptive innovation in healthcare globally, 307 applications from 21 countries, and it was a $5 million award. So what makes ECHO work? This is the last slide. Team-based care. Task shifting is the idea of every human being working at the highest level of his human potential. Requires interprofessional consultation, guided practice, and a mentor-mentee relationship. If you provide all three of these, then human performance will improve. ECHO is also a social network. We have 106 peer-reviewed publications in ECHO. I think about 20 of them, 15 of them are from the VA actually. And but ECHO produces joy of work. And ECHO is a model for all teach and all learn. And what we mean by that is it's not just the specialist teaching. The primary care clinicians teach us too. So for example, when you do oncology echoes, let's say, and you're giving immunotherapy, new treatments, new side effects are emerging that nobody has ever heard of before. I know you're probably aware of that. Even the specialists don't know what to do. But if you have an all teach, all learn format, together we'll decide what the best treatments are on many, many cases together. I'll stop here and thank you for your attention. And I'll take questions and comments and however you'd like to use your time. The rest I've left 15 minutes.
And I've unmuted the attendees on WebEx. If you're listening and have questions, you should be able to come through from audio at this time.
Yes.
So here at the University of Minnesota, we have 5 colleges. Outside the university, like 24 million people. In this area, I think there are another 3 or 4 other colleges. So there's less than 10 colleges in a 2.4 million area, excluding male, which is concentrated. So we have a viral clinic which we started last year, where we have all those people, chemical dependency person. There's the pharmacies always with us.
Sure.
Here. From my calculations and what I read, there's around 60,000 people with hepatitis C in Minnesota.
Yeah.
And very few of them are on treatment, although lately we increased the number of people on treatment. And we're thinking of reaching the red lane, and that's why we were talking anyway. We were leading the program.
Yeah.
I think we have a lot of expansion. And treatment is easier now compared to what used to be the interferon and provided. So you can easily teach people how to handle it.
And Dr. Hassan, that's exactly what ECHO is designed for. If you set a goal that we want to treat all 60,000 patients, which is easily doable with ECHO, then that's what it's. So I'll give you 2 examples of how we are doing it. In the state of Punjab in India, in the last 18 months, what was happening was there is this institute called Postgraduate Institute in Chandigarh, India. It's the leading postgraduate institute in India. They were treating 1,200 patients a year. And we set up ECHO now in 18 months. They've treated 40,000 patients. Cure rate 93%. In the country of Georgia, far away from here, the U.S. government actually came to us. It was a request by their president to the U.S. government to eliminate hepatitis C. They have 200,000 patients there, 5% in national incidence. And we set up ECHO there with the assistance of CDC in the U.S. The U.S. State Department was involved. And we've treated 45,000 patients already in 2.5 years. it's possible. If you were to set up 30 treatment sites all over Minnesota, you can see how you can scale this thing up fast. Firstly, you scale up screening, and then you scale up treatment. And most people actually don't even know how much damage hepatitis C does. But because you're one of the leading liver transplant centers, you see the ravages of this thing all day long, right? And so, I mean, I think we can save thousands of lives that way. At least the CDC has estimated at 28% lifetime mortality of the disease. And it would be amazing. But I also love your idea about partnerships. Dr. Prasad is the chief of medicine there. So we have the chairman of medicine here, the chief of medicine and Hennepin there. And they obviously like each other and want to collaborate. I think it would be amazing to set up joint projects which are solely non-competitive but designed for the welfare of the citizens of Minnesota. It could be very cool. So, but those are the types of things ECHO is designed to do, basically.
I think we have a relationship with almost all in the Twin Cities, besides the VA. I think there are around 4 centers. This treatment state,
Yeah.
place. And we are all connected,
Yeah.
all of them, whether it's Minnesota Gastroenterology or Health Partner, we collaborate. And we collaborate even with Duluth and with the Fargo also, we go there. So we have a network,
Yeah.
which is important. And then we are also part of the target study, which you probably are
Sure.
familiar.
Very well.
We're part of the prioritized study, which is nationwide.
Yeah. And so you'll be tracking the outcomes too, which will be even more beautiful. I think I want to mention that it's not just for hepatitis C for you, because I know a little bit about your university. You can do pre-transplant evaluations at the same center so that people are safe travel. You can do post-transplant follow-up after the first year, 6 months. You can do so many other things. You can do screening for liver cancer, evaluating those ultrasound. I mean, there's a lot. Our platform allows you high-definition CT scans, etc., to be transmitted. Yes, sir. Please.
I'll ask a question which I'm sure you get retired.
Yeah. Okay.
Particularly in
Yeah. So we currently pay for it almost, as I said, all the 200 or so hubs now in the world, right, doing hundreds and hundreds of programs, are either funded by the state legislature. So Missouri gives $3 million a year. Our legislature gives us $2 million a year to democratize knowledge, etc. Or through Medicaid. I met with your Medicaid director on Wednesday night. She's very interested. Marie Zimmerman is her name, because it saves them a lot of money in travel and better access for their patients. About 8 states are funding through the Medicaid programs. They give the universities like Hennepin, large community centers, etc. universities money. We also have departments of health that fund ECHO projects. We have foundations that fund ECHO projects. We have health plans that fund ECHO projects. So, for example, in our case, we have 4 health plans that give us about $1.1 million a year for better care and access for their Medicaid patients. There are also, in addition to that, in addition to the $100 million of funding we have received at the University of New Mexico, another $100 million has gone out from the federal government to other universities to do ECHO projects. The federal government actually does ECHO projects themselves, so they understand it. For example, there are NCI, National Cancer Institute, ECHO projects. There are CDC ECHO projects like that. NIDA, SANSA. So Hennepin has started this amazing ECHO around opioid addiction, funded by the federal government through the Cures Act funding. So yeah, right now the ECHO Act is designed to create a sustainable revenue stream, but right now most of the universities, they either launch through their government or they call their development officer, have them raise about $1 million and set up 4 or 5 projects of ECHO. And once these ECHO projects are running successfully, they tend to attract more funding, because then we invite the Department of Health, we invite Medicaid, we invite legislators all to see it, and then they get it right away. That's how it is.
Do you provide payments to the
No. So right now they have no incentive. So they come mostly because they enjoy the idea of becoming a specialist in a particular area and serving their community. We give them free CME credits for participating. It produces joy of work. That's the main reason, because you know what actually creates value in ECHO is not knowledge. It's love and respect and kindness and empathy and community, and it does that systematically all the time without fail. And we provide all our technical assistance to you for free. So if, let's say, you wanted to start an ECHO, what would the process look like? You would come to see us in New Mexico for 3 days. You don't have to sign any agreements because your university has already done that. And then all you would say is you read the agreement and you agree to it. And then we would train you in 3 days, give you and your nurse, let's say, access to all our software. So we have ECHO Box where all the Hep C protocols, the Hep C lectures, the curricula, everything is stored in it. You can just download. The evaluation templates are there. Grant writing materials are there that you can just download and plug into your grants. We have democratized everything we do, ours and yours and everybody else in the world. And then basically you start your ECHO at that point. That's it. Your chairman will have to pay for your trip for 3 days there, airfare and a hotel, but that's it. First class.
Could you tell us a little about how you measure joy? We have an epidemic in this country for sure, of burnout, doctors that are burning out. Many of us think we understand. Well, how do you measure that you really enjoy their work, that looking at burnout, differences, went before and after programs and so on and so forth? How have you measured that?
So we have measured it through surveys, professional isolation, professional satisfaction. We measured it through focus groups. We've measured it through not just us. There are places like Ontario, Canada, where the government spends between $10 and $12 million funding 20 ECHO projects. Northern Ireland, a country with just 2 million people, they fund 32 ECHO projects. They have looked at all of this through qualitative measures. The CEOs of these health centers have told us that ECHO is the major recruitment retention tool. In the state of Washington, people have already started writing contracts when they take jobs with primary care sites to say that we will only take this primary care job if you allow us to participate in ECHO. And as I said, about 40 of the publications show that. I think the burnout is many, many reasons, but one of the reasons that the burnout is occurring is doctors have cognitive dissonance. Have what we call cognitive dissonance. That means that all parts of our healthcare system are designed right now to increase revenue. Okay? Whereas patients and sometimes doctors are much more focused on quality, access, right? And so in some situations, these two vectors are aligned. Increasing revenue is good for patients, the best thing for everyone. But often these vectors get misaligned. And so when these vectors get misaligned, it produces this dissonance in doctors' minds where they're trying to generate RVUs even when they know the patient needs more time. It's putting all kinds of unusual pressures on us. For example, in Canada, there's provider satisfaction is higher. About 6 days ago, a major survey came out by international agencies rating the healthcare systems in the world. The United Kingdom spends on average about 45% of what we spend on healthcare every year per capita. They came number 1 in all aspects. We were 13th, just to give you an idea. And I think this is the dissonance that I was talking about. This thing is a big problem. I'll be with you. Were you trying to ask a question or no?
Me?
Yes.
Yes, I do.
Yes, please.
Thank you. This is a very inspiring talk. The question I have is really simple and practical, but I'm actually putting out a proposal to do some kind of a telemedicine thing for lung cancer screening in
Yeah.
Indian tribes. They are very interested in liver disease. We should definitely talk. You said it was all de-identified information. So what about imaging? Are you sharing imaging across how do you just don't share that part of the screen or like
Yeah.
kind of basic?
Yeah. You
So like
just cover that part of the
They
screen.
control through the scan on their end and you.
Yeah,
Okay.
right. You just do it, and so you can do all of those things.
So you
Yeah.
don't have to get complicated, like sending the scans over, transmitting the
No.
identified versions. Okay.
Yes, please.
I was wondering, how cooperative are insurance companies with this project, and do you see any kind of a stigma for physicians who have been, or physician assistants that have been trained in this way compared to traditional methods?
We've never heard of a stigma. In fact, these physician assistants become specialists in their area. Their respect goes up pretty dramatically because they become super specialists in hepatitis C treatment. In our New England Journal of Medicine paper, half the people were either nurse practitioners or physician assistants at the other end. In a focused area like hepatitis C or lung cancer screening, they can do as good as super specialists. So, no. In fact, internal medicine doctors refer their patients to physician assistants for the treatment of hepatitis C, for treatment of rheumatoid arthritis, and they write letters back, thank you, Dr. So-and-so, for sending your patient to me. I had the pleasure to see this patient, and the patient has this disease. This is the treatment I recommend. So it just works like that.
But they have their own training. They are already.
Yeah, they are already.
They have.
Yeah, it's just we are making them specialists.
Training.
Yeah, we're making them specialists.
Because we have physician assistants who treat hepatitis C.
Yeah,
Here.
exactly.
University also.
Anything else? Well, thank you for your attention. It was a pleasure to meet you.